Good afternoon. My name is Larry Hodges. My talk today is designing a true telerehab system to meet the COVID-19 challenge. Currently, I'm an emeritus professor at Clemson University. I also work with Recover. So first, some background to put me in context. I am a computer scientist by training with a primary research area of virtual reality systems. I have been working with healthcare professionals for over 25 years, building clinical applications of virtual reality technology. And I have two guiding principles. The first is that I always work in partnership with healthcare professionals to solve real problems using an iterative, human-centered design approach. Working with content experts is key to building good software. I was a faculty member at Georgia Tech for 14 years, where I worked with Atlanta organizations such as Emory University Medical School, the Atlanta VA, Children's Healthcare of Atlanta, and the University of Pittsburgh School of Medicine. Since moving to Clemson, my major partners have been faculty at the Medical University of South Carolina and the Clemson School of Nursing. The second principle is that research must be moved out of the lab and into clinical practice to have the greatest impact. I'm a believer in university and industrial partnerships and entrepreneurship by faculty members. In fact, the majority of VR systems in hospitals and clinics in the United States were put there by organizations that I helped start. Today's talk is an overview of a research and development project that was motivated by an encounter with Dr. Michelle Woodbury, an associate professor and stroke rehabilitation expert at the Medical University of South Carolina, after she heard me speak about my work in using virtual reality in the treatment of anxiety disorders. Turns out she had a list of problems in stroke therapy that needed solutions. Here's some of them. Stroke research indicates that patients with upper limb impairment need 300 to 1,000 repetitions per day in order to regain function. Yet most therapy programs only provide about 30 to 70 repetitions while working directly with a therapist in a clinic, and that only about 3 days per week. Patients are then sent home with a piece of paper describing exercises they should do on their own, but compliance with home exercise is minimal because exercises are boring and sometimes impossible to do because of the level of impairment of the stroke survivor. Research also shows that the recovery window lasts beyond the 1-year post-stroke mark, but patients generally get discharged after a few months. As a result, few patients achieve the level of recovery that is possible. So Dr. Woodbury's question to me was, could we design a virtual reality game program that would motivate and guide stroke survivors through therapeutic exercises in their home as a way to improve compliance and recovery? So this seemed like an interesting problem that my team could contribute to. And even before the current crisis caused by COVID-19 pandemic, I learned there were plenty of existing challenges for stroke rehabilitation. It's a national problem, particularly in the South, and South Carolina is the belt buckle of the stroke belt. But there was also reasons for optimism that access to more therapy can be effective in recovering function. There was a need for better access to therapy, motivation for better engagement, and larger therapy dose that I thought we could address with a virtual reality gaming system that could be used either in a clinic or as a telerehab system. So in this talk, we'll focus on stroke rehab, since that has been the driver for much of our current research and development. But most of what we say also applies to a broad range of physical rehabilitation. So we began this partnership with multiple discussions of our clinical partners led by Dr. Woodbury to understand what a rehab system should actually do. So here's our initial list. It should be engaging in order to motivate use, but also easy to use and set up. There cannot be a long list of gameplay instructions to get started. Given the disabilities of most stroke survivors, it should not require the user to hold a controller or wear any special clothing. So the best approach seemed to be a video-based tracking, but it also must work if the patient is standing or sitting or even in a wheelchair. It should be able to be easily modified by the therapist to match a patient's needs, either in a clinic or remotely for home units. It should be patient aware, by which we mean it should be able to distinguish the patient from the therapist and from other people or objects in a room. For video-based tracking, this is actually a hard problem. We also thought it should automatically generate reports so therapists can make clinical decisions and patients can actually see their progress. And this could also be important for insurance reimbursement to have documented evidence that the patient is actually making progress. And we wanted to make sure that it would guide patients through exercises that ensured that they did them properly. So most patients don't have a full range of motion, but seeing their movements in full range is helpful to the neural rehab process, partly based on mirror therapy research. And unfortunately, patients cheat, i.e. they use compensatory strategies, such as moving their trunk instead of their arm to pick up their hand, and our system should recognize these motions and not reward them. And most patients lack motor control, so the system should give them credit for getting close to completing a task if they make something approaching the correct movement. Oh, and one last thing, it can't cost a lot of money because a lot of stroke patients don't have a lot of money. So this was our initial list of capabilities for the program. We also thought a lot as computer scientists about what design features we should include in the system. The underlying technical design needed to be carefully planned. And to be honest, most academic prototypes only work in the lab with a graduate student hovering nearby to maintain it until they have enough data to write a research paper. We wanted to build a system that would work in a stroke survivor's home and that would be easy to update and to maintain. So it had to be flexible because the technology is always changing. So it had to be agnostic as compared to hardware, so we could change out hardware. We would probably find hardware that we hadn't thought of earlier, so it should take input from other devices other than the initial ones we started with. It should be able to output data in different formats. And we also realized that many things we might want to plug in later or send information to in the future might not yet exist. So we had to make sure we plan for that. And we wanted to put this in a patient's home. So the footprint had to fit in a home. It can't be large. It can't be very complicated. So after more than a year of iterative design with our clinical partners, we ran our first inpatient pilot study with 10 adult stroke survivors. They came in 1 hour per day over 5 days. And the result was that we saw significant improvements in elbow extension and reduced compensatory movements. And I want to show you a short video to show you one of the participants using the system so you understand better how the system works. So the game is displayed on a large screen TV. A Microsoft Kinect motion tracking system is used to track the user's joint movements. In particular, a virtual arm on the screen mirrors the movements of the user's real impaired arm. The object of the game is to reach out and punch, or touch if you're not into violence, ducks when they pop up. And this is the day one for this participant, the first time she had used the system. And she actually really liked playing the game. She's really working hard at it. But I want you to notice the compensatory trunk movement and the compensatory shoulder and elbow movements as she tries to reach out and hit the duck. So you can see her body continually moving. And these types of compensatory movements can cause further harm to the patient, such as shoulder tears, actually similar to what a Major League Baseball pitcher might develop. So the system is designed to not reward these movements. So they really don't do any good for you to lean forward or to move your shoulder, but will only move the virtual arm forward correctly with true shoulder flexation and elbow extension movements. Also notice that the duct she's trying to hit, she can't get to. She's unable to hit the duct target on the screen. The next video is 5 days later. So same participant on day 5. Notice there's a significant decrease in trunk compensation. There's a significant decrease in compensatory shoulder and elbow movement. And you watch, the very same duct is going to pop up and she's going to nail it the first time. So this was only after 5 days of therapy, 1 hour a day using our system. Both our programmers and our clinical people were very excited about our pilot results. So we've been working with the system for several years, and we've had to continually pivot ideas and technology during this project. Computer and hardware is continually changing. One of the changes was one of the original hardware trackers we used has been discontinued, so we had to find other tracking technology and test it. Our outputs in order to our documentation and charts, we had to look at all kinds of different formats, especially to support different electronic medical record systems. Also, there's now many options for telemedicine systems, audio visual systems. So we have many options of ones that we could partner with in order to have video conferences back and forth along with real therapy. And of course, the big change is COVID-19, which has been a major negative for society, but it has pushed the need for innovation in telemedicine. So COVID-19 pandemic has created an openness to and a need for true telerehab to support recovery during social distancing. And by true telerehab, I mean not just teleconferencing back and forth, but the ability for the therapist to actually help guide their patient through proper rehab movements using our system. And now we're in the transition from our initial prototype research systems that were mostly in clinics to a compact in-home system. So the result of the past almost 10 years now of studies and development is an evidence-based, true telerehab platform that goes beyond simple teleconferencing to provide therapist program guidance, feedback, measurement, and progress reporting. The complete system consists of a computer, software, camera-based tracking, and it's all packaged in a small case that connects to a patient's own TV set. So when it arrives at your home, you open the case, you plug it into power, you plug it into your TV set, and it's ready to go. Here's a short list of some of the key features of the system. And it turns out that stroke survivors in our tests actually like playing our games. So they do more repetitions, they get more therapy. And as they play, the system automatically collects data on their progress and produces charts and graphs that document patient progress. The therapist can remotely adjust the system to meet patient needs and abilities. And we provide clinical protocols for matching games to functional goals and activities of daily living. For the patient, there's nothing to wear or hold, and they can play rehab games on their own schedule. So therapy is not just at a particular time, but the game is always available. And that turns out to result in a lot more gameplay, which is a lot more rehab exercises. So a good question now is how well does it work? So we're just now completing an NIH-funded telerehab study. The basic design is that it was a 6-week study. There was one home visit where the system, prototype system was delivered in the home and set up, and the stroke survivor and usually a helper were trained in how to use it. And then there were weekly e-visits by the therapist. And we compared our in-home, recover in-home system to a control group. So the results were that our Recover system had a significant improvement in functional motor skills and impairment reduction. It provided a higher therapy dose. Patients averaged about 1.5 sessions per day. Each session, they got about 540 repetitions of gameplay. And they were twice as likely to actually adhere to the program they were supposed to be doing. They were engaged for 59% more days and completed 27% more sessions. Now, over 6 weeks, this is a big difference. So for a control group, they average about 2 sessions a week with about 50 repetitions per session for about 600 repetitions of the movements they were supposed to be working with over 6 weeks. The Telerehab group, using the Recover at Home system, totaled 22,000 repetitions on the average during the 6 weeks. So 22,000 compared to 600. So the amount of therapy they actually did was much, much greater. And in the real world today, few systems are adopted unless they make financial sense. True Telerehab makes a strong case for more therapy at a lower cost. You reduce or eliminate the cost of paying a therapist for driving time to go to patient homes, so the cost per patient is reduced. That time can now be used for e-visits with more patients. A conservative estimate of cost savings and increased productivity is shown in the 2 bar charts in the figure. So on the figure on the left and the leftmost gray bar, we assume 3 in-person visits by a therapist per week, including patient time and driving time at average salary, which would be average for this region of about $80,000 a year for a therapist. So the $906 would be the cost to deliver therapy to that patient. The middle bar would be 1 in-person visit per week, and the remote monitoring through the Telerehab system and a Telerehab session with the therapist once a week. And the orange bar on the right of the leftmost chart would be the estimated cost of 1 initial in-person visit, then Telerehab for all other patient contact. So the difference in cost for delivering actually what could be better therapy for the patient goes from $900 to $500. The bar charts on the right indicate the productivity of a therapist, with the gray bar being a caseload capability per month for all in-person visits, then the mixed model, and then all but 1 visit done with Telerehab. The result is a potential 8-fold increase in patient load in the same amount of time per therapist. So where are we in this project now? If we go back to the beginning of the talk, we checked all of Dr. Woodbury's initial boxes for the features that this solution needed. We've had what have been very successful results of our NIH study that supports the efficacy and cost efficiency of using asynchronous Telerehab. And now we're in a process of moving to the commercialization phase. We have several systems out being used by patients now, and still collecting data and getting feedback from therapists on how to make this as usable as possible. And I'd like to end this talk by thanking all the people who have supported us over the years. We've had funding from both the National Science Foundation and the National Institutes of Health, and small grants from SC Launch at SCRA. We've had investment from the Iron Yard, Concepts of Companies, and SC Launch. The 2 universities, Clemson and MUSC, have been supporters throughout this. And the Microsoft Imagine Cup has actually, and Microsoft has provided also resources for us and encouragement. I'd be glad to try to answer any questions you have. Thank you very much.